Everybody, and a warm welcome to a very significant topic that we'll be talking about here, presented by Ecclesia Park. And we are very fortunate to have an expert in the field joining us today, Dr. Edmund Schutze. First of all, I'd like to say that end-of-life care, or the end of life as such, is certainly not a very popular topic, not something that people would like to talk about. So we're always celebrating a new baby, new life, but when it comes to the end, we are quiet and we prefer not to discuss it because we don't want to keep hope from the person involved. I often hear older people say that they're not scared of dying, they're not scared of death, but they're scared of the actual road towards it. They're scared of the process. And that's why we have to actually look at this last end of one's life. I came across a paragraph written by Sigmund Freud, who said, "I'm as weary as it is natural to be after a hard-working life, and I think I have fairly earned my rest. The organic elements that have held together for so long are tending to fall apart. Who would wish them to remain forcibly connected any longer?" I thought that quite meaningful. About Dr. Schutze, Ecclesia Park often makes use of the services of his practices. I can just say that he completed his MBBCH from the University of Witwatersrand in 2007, and he did his postgraduate diploma in palliative medicine at UCT in 2009. He completed his community service at Witkoppen Clinic, and in 2011 was appointed casualty medical officer at Bedford Gardens for 7 years. In 2015, he started a home-based care and palliative medical practice and acquired an additional practice in September 2017. The practice offers a multidisciplinary team approach with focus on medical care for patients in the comfort of their homes and at facilities. And there, I would just like to stress the fact that the multidisciplinary team approach is really the way to go, and especially coming to visit patients at their homes or at their old age homes. We find that very comforting to know that there is a service like that. So, Doctor, I'd like to give over to you. Thank you for being here today.
A big pleasure. Morning, everybody. I'm just waiting for the slides to be put up. Amine, if you can just sort out the slides show for us. Thanks for the invitation and for the opportunity to actually talk to a broader group of people. I asked this morning because I wasn't quite sure who I was addressing, but I know there are several families from Ecclesia on this talk. There might be a number of doctors, a number of nurses. There might be people from Unique Health on this talk as well. It's a really, really broad topic, this. I think almost everything that I'm going to discuss today, you can actually make a topic of each of that. So, and because we don't have the time, I was really asked to do a presentation on really the kind of work that we do, which is palliative medicine. What palliative medicine is, why do we do palliative medicine at the end of the day? When do we start palliative medicine? And when is a person at end of life and what happens at end of life? I haven't geared this as a very academic talk. This is a very intuitive talk, I think, at the end of the day, addressing some of the issues that people do face when they are faced with death and dying, or that carers and families face, and the healthcare professionals face. And it is really a complex system of things that need to integrate to make this a journey that one actually has control over. It's not something, as was commented on initially, that people like talking about, but I think it's a very needed topic that needs to be discussed, because this is the only way that you can actually negotiate what is essentially a really difficult road, either as a patient or as a family member or as a carer looking after these patients. So I'll start just by raising the topic, what is palliative care? So the World Health Organization basically defines palliative care as an approach that improves quality of life for patients and their families facing problems associated with life-threatening illness, through the prevention and relief of suffering by means of early identification of those problems or the disease, impeccable assessments, which needs to be continuing, and treatment of pain and other problems that do exist. I think it's really important to understand that life-threatening illness is not just defined as cancer. Most people think of cancer as the life-threatening illness that defines everything, and everything revolves around that. And we initially, when we started in palliative medicine in South Africa, in the very early days, had no support. After that, we actually had support from medical aids, or from some of the medical aids for oncology patients. We're now at a point where not even all the medical aids have palliative benefits in their medical aids. Those that do have, some of them have palliative benefits for oncological as well as non-oncological conditions. But there are some medical aids who are still restricting palliative care basically just to oncology conditions. And then there's a whole host of medical aids who still do not really recognize palliative medicine or the fact that patients might be at end of life and need assistance. It makes it quite difficult, therefore, to actually negotiate this road. I think not only for medical doctors, but also for carers and for families and for patients who, when they get to a point in life where they might need the intervention or help from palliative practices, face huge obstacles in terms of determining how you walk the road, and with the problems associated with it. The approach at the end of the day is a multidisciplinary approach. It's holistic. So when I say multidisciplinary, although we don't in our practice specifically have dietitians or social workers or physios or OTs or speech therapists for that matter, we do have we do have doctors and nurses. We collaborate with all these other auxiliary services and would always be able to offer patients those kind of services as a benefit to try and ameliorate and make things much easier for patients and for families and coordinate care. So it's really, it is quite complex, but it's quite simple once you have a system in place and once you understand. I'm going to just go back to the previous slide. Sorry. Understanding that it's holistic, and when we say holistic, it's really important to understand that as human beings, we don't just exist in our bodies, okay? There is psychosocial issues that surround patients and families that hugely impact on how people actually experience life and death, for that matter. And there's also huge spiritual needs, which is all varied. As we know, there's many religions, there's many different cultures. So people have different cultures. They have different ways of approaching death and dying. And people in religions have certain, I don't know what the word is now. Sorry, I've got the word, it's out of my head now. There's certain rituals, that's the word that I was looking for. Certain rituals that now need to be performed either before or after death, which might be quite foreign to people who are brought up in a Western culture with a very Christian background. So it can make the care needs for families and for patients quite difficult if you don't have some kind of understanding around what is happening with those patients and with the families. You can go to the next slide, Amane. Thanks. Right, so what is palliative care? So in essence, really, we're there to provide relief from pain and other distressing symptoms. So these are physical symptoms that we're talking about at the moment. As we all know, as processes happen, and even normally in life, you know, we suffer from pain on occasion, nausea, diarrhea, heartburn, headache, constipation, difficulty urinating, infections. All those things seem to kind of like culminate in chronic illness and chronic disease, and very often starts accumulating and gets more distressing. So part of what we do as palliative practitioners is to try and address some of those physical symptoms and actually treat those physical symptoms. I think what's really important to understand is that in palliative medicine, we affirm life. So while there's life, you keep on living. But we also do regard dying as a completely natural process. And the intent that we have in palliative medicine is that we would never seek to hasten a death, but also not to postpone a death at the end of the day. So for us, as long as this process is a completely natural process, we will support that process as a natural process and just make sure that there is comfort during that process. And I think that's really important to understand, because we often arrive at patients or families where we actually get asked, is there not something we can give that will take everything away and get this over with? And it becomes quite a topic of conversation, I think, for families, for patients, between healthcare professionals, and it's very topical at the moment, I think, in South Africa. It's important to understand that it integrates the psychological as well as spiritual aspects of the patient care, which I alluded to a little bit earlier. It's really important to understand that you cannot separate your body from your mind and your spirit. There's a connection between those three, although, albeit it's not a physical connection that we can see. And if one of those parts that makes us up as humans is in deficit, it has a huge impact on the other parts of that three-part in that trilogy, so to speak. So our aim is really to offer a support system to help patients live as actively as possible until they die, and to offer support systems to help families to cope while patients are ill and in their own bereavement. We use a team approach generally to address the needs of patients and their families. And bereavement counseling is something that is important even before death, because we all, to a certain extent, start grieving and suffer loss, which eventually leads up to a bereavement at the end of the day, which can be complicated if your grief hasn't been addressed. So it's really important to understand that this is something that starts early and kind of like continues, and there's not really a continuum in terms of grief or how long that lasts. And it's very different for different people. I think what we're trying to achieve at the end of the day is to enhance quality of life, such as it is. And in doing so, you could actually positively influence the course of illness for patients. It is important to understand that palliative care should be instituted early in diagnosis for patients, but very often isn't. And I think that some of the boundaries that we have in terms of that is sometimes doctors aren't prepared to say, we need to go into a palliative care system, because doctors are generally taught to save life and to cure people, and find it really difficult to make the transition from curing to caring, so to speak. And I think at the end of the day that the other thing that happens is sometimes patients aren't ready. Patients sometimes have a devastating illness like a cancer and just cannot come to terms with the fact that they are in fact dying. So they find it quite difficult to then get approached or get asked to get involved with a palliative care practitioner, because they're on this road of chemotherapy, radiotherapy, and all the other therapies that goes with that in order to prolong and sustain life for them. And very often, some of the work that we do gets left until really, really late in the illness. It doesn't mean that if you're under palliative care that you don't do blood tests and you don't intervene and you don't make decisions around how to treat a patient or how to make a patient more comfortable. But it certainly starts bringing up questions around when is it appropriate to do things and when is it appropriate not to do other things. And that's a discussion that happen on a continuum all the time with all our patients. It's really important to understand that if patients are in a mode of where they are still treating, that you guide them appropriately as to what would be appropriate investigations. Why would you do the investigations? What's the result of those investigations, and what can we do about it? Because otherwise we are going to be dealing with people who want to fix things all the time, and it becomes more and more difficult as this journey gets further and further into end of life and potentially dying. Now you can go to the next slide. This is just a diagram really to address kind of like when palliative services should be implemented. And I think the answer really is as early as possible, provided that there's no barriers for access. So sometimes it's simply a question there's no support for people. We've got lots of communities where there is no access for palliative medicine, or people live in remote areas. Sometimes, as I said, it's the doctor, sometimes it's a family resistance, sometimes it's the patient resistance. But ideally, for us from palliative practitioners' point of view, we would like to see patients early on diagnosis, because this is a process and a road that we actually walk with patients, and our role becomes more and more important as people's perception of where they are in this whole journey for themselves start changing, or as people get word from doctors that there is no more curative treatment, and very often get told there's nothing more we can do for you, literally. And in palliative medicine, we think about it very differently, because for us, there's always something you can do. You can always relieve symptoms. You can always make a patient feel better. And sometimes it's the small things in life that makes difference for patients, not the big things overall. But you can see in this diagram that initially that therapy to modify disease is something that initially is really prominent. And our role is less. And then as disease progresses, our role tends to become much bigger until the eventual death of a patient. And then there's this winding down of interaction with family members post-death of a patient during that bereavement and grieving process, or referral into a system where that is possible to do, so that there's a continuum for families after death of a loved one. It's also important just to note at the bottom of the diagram, although there's a time element here, and I'll talk about that a little bit later, sometimes things happen unexpectedly, and you might not have a disease which is chronic, which might potentially cause your death over a 2-year period, but something happens and you go from someone being really healthy to someone who's suddenly bedbound and facing death, which is a very different scenario. And that comes with its own problems in terms of how one interacts and how people, I think, negotiate and almost negotiate this road that they suddenly thrust upon. So it's really important to understand that palliative care can happen at any time. We have a lot of general GP practice patients in our practice who are not dying, but they are elderly, they've got chronic underlying conditions, which is causing problems for them. And we manage those, because all those patients at some point in time will actually become palliative patients, so to speak, and eventually face end of life and face death. And I think it's a reality for all of us. The next slide, Amine. So why do we do palliative care? I think at the end of the day, the definition of what palliative care really is part of what tells us why we do it and why we should be doing it. And I think it's something that we should be taught as doctors in a much earlier level and in much more detail, because I think it gives a lot of balance in terms of what we do in medicine for patients. And it helps to orientate us towards the fact that we can't cure everything and that we can't save everybody. I think part of the reason we should be doing it is it integrates and simplifies care, because very often we find that there's so many specialists involved in patients' care. So you get to a patient and they've got a medical oncologist, they've got a radiation oncologist, they've got their GP that they're still seeing, they've got other healthcare workers like physios, OTs, speech therapists involved. And sometimes they have multi problems. So they don't only have cancer, they might have heart failure, they might have renal failure. So you might end up having a physician involved, you might have a nephrologist involved. And it really becomes complex because patients and families eventually don't know who to talk to. So part of what we do is to try and integrate and simplify care for patients so that you can actually make decisions. It is certainly cost saving. We know from talking to medical aides, and it's a big reason why medical aides have started paying for palliative practitioners to do the work that we do, is they're clever guys that do all their projections and stuff. They know that it's cost saving. It's just a pity that a lot of the medical aides aren't on board and that a lot of them aren't remunerating, I think, palliative care practitioners to what they should be. But it certainly saves the medical aid a lot of money in terms of hospitalizations and in terms of unnecessary procedures, unnecessary surgeries, and unnecessary visits to other healthcare professionals, because we are able to give a lot of this care at home and rather spend the money on a team that actually looks after the patient at home. I think the other thing that has become really prominent in the last number of years and is the desire of patients and families not to have recurrent admissions. We often deal with patients where we have like 6-7 admissions over a last 6-month period. I currently have a patient at the moment that out of 95 days, the last 95 days, have spent 75 days in hospital. And it becomes really distressing, I think, for the patients as well as the families, because there's no end to this and there's no resolution and there's no talking about what happens. For us, it's quite important in palliative medicine that we set goals of care. So goals of care for us is, what do patients want and what do patients not want? It's really important to understand that. Patients sometimes make decisions for themselves based on information that they have. And sometimes it's the wrong decision for them when they look back, because they haven't had all the information. So part of what we do is to sit down when people need to start making decisions about their healthcare and what it is that they want and what they don't want, and actually tease out to a large extent, what do we want and what don't we want? What's important for you as a patient? Is your physical needs important? Is your spiritual needs important? Is your psychological needs important? And if so, which of those do we attend to? And we try, and at the end of the day, set up a system that works for the patient and the family, but it should always be patient-centered. It's really important to understand that we listen to patients and what patients tell us. And if there's discrepancies between what the patient tells us and the family tells us and what other healthcare providers are telling the patient or the family, that we sort those out, because otherwise we cause immense confusion for patients and for families. So we discuss things like, what is important for you in terms of your religion, and how are we going to accomplish that you still interact and have that? How important is socializing for you, and how does one actually achieve that patients can continue socializing to a certain extent? How important is your psychological, your friends, hobbies that you have? Those are really important things to try and integrate into patients' care at the end of the day. And ultimately, when it comes to medical decisions, what is important for you as a patient? We have patients who get diagnosed and would tell us, I am not doing any treatment. I'm never going back to a hospital ever again. There are even patients that will go as far as, you do not put me on another antibiotic. If I get another infection and this infection kills me, it's okay. I'm ready to go. We're not going to resuscitate. You're not going to resuscitate me, and you're not calling an ambulance. So this is the kind of stuff that we generally would talk about, which is a different conversation than advanced life directives. So advanced life directives speak much more closely to what many would know as a living will, in terms of what you want and what you don't want on a medical level. So it's not necessarily about the other goals of care that you have as a patient for yourself, but really centers around, what do and don't I want to do if something goes really wrong? And this is where the conversation around resuscitating patients come in, about, do you want to be on a ventilator? Don't you want to be? Do you want to go to hospital, for that matter? Is one of those things that's important. Would you look at something like pig tube feeding? And for people who don't know what a pig tube is, it's basically a tube that gets inserted via the skin into the stomach, and we can feed patients that way, because we have a lot of patients and families where they would require that and would request that, not understanding the complications of putting in a tube to feed a patient versus the complications of not putting a tube in for a patient. So what we very often do in these advanced life directives is go through these things with patients and families so that they understand the differences between doing things and not doing things. And it's very interesting when you start speaking to families and patients, they don't always grasp that doing something is not always good until you actually point out the negatives and the positive for them. So for us as palliation practitioner, when we talk about advanced life directives, we try and talk to patients, if they're able to, or to families around, it's not just you need to do a pig tube because otherwise your loved one is going to die. You're basically killing them if you don't put a pig tube in. Because life is not that simple, and procedures aren't that simple, and medical care is not that simple. So, because if you give patients or families that kind of message, of course they're going to put a pig tube in. But if you start telling them the negatives of putting a pig tube in versus the positives of putting the pig tube in, and compare that with the negatives and the positives of not putting a pig tube in, then you're giving patients information, and you are giving them a good view of where they and if you do consider those things, you then end up with a good decision, because otherwise it becomes an emotional decision rather than an informed decision, which I often find in the kind of work that I do, that patients have not had informed decisions, or families for that matter, when they try and make decisions for themselves or for loved ones. I mean, we can go to the next slide. Okay, so just a short thing on when is the patient at the end of life. I put it there, not always clear, because it isn't always. You know, like medicine is not an exact science. Death and dying and life is not an exact science. There are certain things that we would sometimes look for and see, and sometimes we would definitively tell people that, yes, you are dying, or we can say to a family, your loved one is in a process of actually passing away. But it's a really complex system to try and figure out sometimes. And that's why when people generally ask doctors, so how long do I have to live? Most doctors shy away from that answer, because inevitably they're probably going to be wrong. And it's just the way that life evolves and how it is. I think what's important, and I try to keep it quite simple because it's some of the language that we often use in conversations. So we all understand that if you have an acute event like a massive stroke or a massive heart attack, or you fall off a building and you have a brain injury, that you have an acute precipitous event, which I call the cliff. In other words, you're well and something happens and you're facing death, or you die as a result of it. And that anxiety that it provokes and the expectations that it provokes in patients and in families is very different to a chronic condition where there is this roller coaster and slippery slope, and one step forward, two steps back. And that's what I meant by that next, by the next sentence. People who have looked after patients, either elderly patients or relatives or friends who have been ill chronically, will understand when I say that this is a roller coaster ride. It's up the one day, down the next day. No day is like the other. No hour is like the other, and no week is like the other. And it makes it really difficult to get a grip on your emotions and where you're going, either as a patient or as a family member, seeing this when you're dealing with that, because the road is never smooth and it's never the same. So you can never predict. I think the difficulty that people have is, and I always say to people, understand you can only really control the moment. We cannot change what's been, what has happened, and we've got no control over what comes across us in the next 5 minutes, 10 minutes, tomorrow, or next week, or next year. We can only, at the point in time when that happens, make decisions. But in planning, it makes those decisions more reasonable and it makes the decisions more logical. So it's really important to understand that when you deal with chronic illness, that you've got this roller coaster ride that you're going on as a patient and as a family member witnessing this. And I always say to people, you're on a slippery slope when you have a chronic condition. And that slippery slope is something can really happen and push you off the cliff, or people get sick, they go to hospital, they get treated, they come back, they get better. And I think people who have gone through this and are going through this at the moment would probably affirm what I say, that when patients go through these in and out of hospital stays and in and out things happening to them, breaking a bone, going for surgery, getting an infection, yes, we get patients better, but it's almost as though we have this one step forward, two steps back in dealing with these things all the time. So yes, we kind of like fixing the hip, but somehow we never as mobile and as functional as what we were before that. And that necessitates a change in how one thinks about your own health. It necessitates a change in how families have to deal with a patient. And it's got a huge physical and a psychological impact on patients when you deal with this. I've put the honeymoon in inverted commas here because we often have this concept towards the end of life, when we see patients at end of life, that we have this 1 or 2 hours or 1 or 2 days of brightness that patients sometimes experience in this road that they walk when they're busy dying, where suddenly they clear, they communicate, they eat a bit better, and they're almost like their old selves. And it's important to understand that we often see that, and very often that is a preamble to the fact that a patient might pass quite soon. And we see this quite often in the work that we do. We often find it's a time when patients suddenly reconcile with family members, where a lot of stuff that they've been worrying about, because they've got clarity, they sort out financial affairs, they sort out legal affairs, they sort out unresolved issues with friends, with family, which then at the end of the day allows them to go. So honeymoon period is sometimes a bit of a false hope, but it's a wonderful time to enjoy with patients. But it's important to also understand that very often when you see that, we very often warn families, just be cautious, because it might also signify that things are changing and things are busy happening. So very often during that time, and during the time when a person is at end of life, they start sorting out affairs. And you would have experienced that if you've worked with patients or seen patients or family members going through this spiritual journey that they're on, the psychological stress and distress that they're suffering, and sorting out legal and personal affairs. And it's stuff that we always address when we do palliative medicine, because we know that if patients are in spiritual or psychological or personal affairs, the stress, so to speak, because they haven't dealt with things, it makes this process at end of life a lot more difficult. The only concept that is kind of like quite steadfast for us generalist palliative practitioners is when we talk about patients, about how long patients have, is this concept of hours, days, weeks, or months. And it really revolves around the fact that we know that if patients are stable for months and months on end, we're probably looking at months or years. If patients start deteriorating weeks at a time, the time period gets better. And if patient starts deteriorating on a daily basis, we're looking at days or hours for that matter. And it's sometimes quite handy to have that in the back of your head because, as I said, we just never know. Vitals can sometimes tell us when a patient is at end of life. But I have also been caught unawares, and it still happens. I've had patients who had a massive stroke and for 4 days never wake up. Okay, and we think that they're dying, and we're busy preparing the family that this patient is probably in the process of passing. And 4 days later, the patient starts waking up a little bit, starts eating a little bit, starts talking a little bit. They're not back to what they were, but they're certainly better than the previous 4 days. And that really throws the cat amongst the pigeons when things like that happen. It can be quite a difficult road, especially if you've had a discussion with families and family members around that we think this is the beginning of the end. Because when a patient suddenly changes like that, it gives them hope that the patient is getting better again. And very often that is not the case. Very often it's a temporary recovery, and it's not a recovery that still is able to support a patient's life. But it makes it more distressing for the patient very often because they're sometimes not able to verbalize what is wrong with them because they can't talk if they, for instance, had a stroke, and they can't move. And you can see the panic that sets in those patients, and then the panic ensues in the family as well because they understand and they can see what's busy happening. And kind of like tell you, well, you told us the patient's dying, now the patient's not dying. So it can be quite a tricky one. So in saying that, although I've been doing this work for a long time, I'm always cautious around advising when a patient is at end of life. Sometimes it's very, very clear. Sometimes it's not so clear. So I always have a reservation when I start discussing things like this with families, because it's understanding the intricacies and the underlying stuff that's busy happening that helps you to enable you to understand whether a patient is at end of life or not. But patients don't read textbooks, I always say. So don't treat the textbook, treat the patient. So it's really important to understand that. Now we can go to the next slide. The next 2 slides is really the last 2 slides. And it's really just quickly to kind of like tell people what happens, I think, physiologically, but also psychologically with patients and with families during end of life. So very often we would see abnormal vitals. And I brought this up because I think it's important to understand when patients are dying, it serves no purpose to monitor vitals all the time. All it does is it causes stress. If a patient is in the process of passing, you have to understand that normal vitals are going to start changing over a period of time. So we always encourage patients. So we have this problem in ICU when I do consultations in ICU and we know the patient's busy passing. ICU staff are almost mandatory, have to put the systems on so you can see the heart rate because they record all the vitals for these patients. But what I find often happens is families stand there watching monitors and are so obsessed and involved in watching what's happening with the patient's blood pressure and heart rate that they actually forget the patient is lying there, and just to be with the patient and touch the patient and to talk to the patient. And I think the same thing at home. So we often say to family members when it really gets to a point where patients are at end of life, don't monitor the vitals anymore because it's just psychologically going to stress you out. We do the vital monitoring when we do visits to the patients, and very often at end of life, it is on a daily basis. And we use that simply to gauge and to help our conversation with the family around what's happening. But in general, what you would find is that heart rates would initially be stable, eventually maybe start going up. And if it's not because of pain or anxiety or something, it's because of a physiological compensation trying to keep the blood pressures up. And eventually that heart rate will then slowly start going down, 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 down. Same with the respiratory rate. You might have a good respiration, and I think it's down at the bottom, and I'll go to a bit more in detail towards the bottom, towards that. But respiration can change. The saturations, those little monitors that people put on their fingers that everybody now knows because of COVID, that starts changing. So the oxygenation starts dropping. And it just means that people get overwrought with what's happening rather than focusing on the patient. It's important. I put this point, everything slows down, because I think it's important for me, because everything slows down really means that sometimes people have the sense that when you have a bad heart, that's what's going to, at the end of the day, kill you. Not understanding that when you are in the process at end of life, your brain function changes, your sight might change, your heart changes, the way your lungs function changes, the fact that your gut changes, your swallowing changes. There's lots of change. So it's a multi-system change that actually is for patients. So we all know swallowing becomes more difficult for these patients towards the end of life. And it makes it really tricky because we have a lot of angst around fluid intake and food as family members and as carers looking after patients, thinking that patients are dying because they're not eating and they're not drinking. Where in reality, I think the reality is our bodies for thousands of years have been dying, and our bodies are attuned to dying. I think very often it's our discomfort as people watching from the outside, seeing what's happening, that triggers all the emotions of wanting to feed a patient and wanting to give fluids to a patient. And understanding that if swallowing becomes problematic and you push food and fluid, you're going to make the dying process a lot more difficult for patients, is a concept that people find a little bit difficult to understand initially. And also, even if a patient can still swallow and drink, and a patient might say to the family members, I'm not hungry and I'm not thirsty, and family members, despite that, start giving, understanding that if your bowel activity starts slowing down and the absorption and the gut motility starts going down, if you keep on pushing food, all you're going to do is all that food is going to sit in the gut, and eventually the patient will be really uncomfortable, get very gassy, and possibly vomit even. So it's really important to understand that there is a multi-system change that starts happening. Circulation gradually diminishes, and you would find that if you are with a loved one and if you've experienced it before, one of the things that you would very often see is that there's changes in the temperature of their hands and their feet, and there's also color changes. So they become a bit mottled or bluish. The nail beds start changing, and those changes systematically go up. So initially it's hands and feet, and then eventually you can see it in the legs and the arms as the body tries to compensate. So that's one of the things that we would generally see. Respiration changes are important because people very often have a lot of anxiety about patients can't breathe or they have difficulty breathing. So understanding that if you hydrate a patient with an IV drip too much, and they're actually in the process of dying, that you're going to cause what we call pulmonary congestion or pulmonary hypertension, and that fluid is going to accumulate in the lungs and make breathing for the patient much more difficult. People need to understand that and acknowledge it, because otherwise family members do ask you to put drips on patients. But it actually prolongs a death and dying process, which is part of what we're saying is counterintuitive for us as palliation practitioners. People often talk about the death rattle, and in essence, really, it is secretions that sit in the upper airway because of the swallowing mechanism that starts diminishing. And people often lie on their back, and whatever little they do drink of it, and if the salivary glands are still excreting, you do get the accumulation of all this fluid in the back of the throat, in the what we call the nasopharynx, and then the upper airway. So when patients breathe, that breathing in and out, you get this kind of like almost like a bubbly sound, is what people will call it. What people used to call a death rattle, which I think is such an unfortunate term we use, but people still use it. So very often we can actually get that better by making sure that we understand the process of food and fluid giving. And sometimes it's a positional change. Sometimes if you just turn a patient the other way, the secretion moves, and the sound gets better or disappears. I think it's also important to understand that if you hear patients with death rattle, very often at that point in time, patients aren't aware of this happening. So they're not experiencing what you think they're experiencing. It's your experience of seeing and watching that makes it uncomfortable for you. Patients are not aware of this actually happening. But it's still not a nice sound as a carer or as a family member to listen to when you have an ensuing death happening. The other thing that often happens is that patients start what we call chain stoking. And it really is just, I'll try and explain it simply. So what happens is patients breathe and they stop, and they breathe and they stop, and they breathe and they stop. And it's not necessarily one breath stop. They take 2-3 breaths, they stop, and you get these pauses in between the breathing. And those pauses generally tend to get longer and longer. And it can be quite nerve-wracking if you as a family member sit there and watch a patient breathing, because they can sometimes stop breathing for 45 seconds or even a minute before they take another breath. And you're sitting there and you think, okay, my loved one has died. And then the next minute they start breathing again. And you kind of like, and that angst that builds up around that. But it's important to understand that process. And when you see that happening, that's one of the things that does happen at end of life, which gives you some kind of indication that things are changing. The other breath that we often hear people referring to is this gasping, and they often would phone the practice or message on the groups that we have to say that the patient's gasping. And they find that quite terrifying as family members. Please note, patients at this point in time really are not aware that they're not really breathing, because they are actually very, very close to death. But I think it's that mechanism of what people see as a fish breathing out of water, trying to get breath, that makes people anxious. So just be aware that that's another thing that can possibly happen. Sleep or dreaming is quite important in the dying process, and I think I've got a little bit more on the psychological stuff on the next page. But it really enables, we all need sleep. If we have a bad night's sleep, we don't have a good day. Same for patients that are at the end of life. What is important to understand is that sleep patterns sometimes do change. So they sleep much more, and sleep increases over a period of time, more and more and more. They're more sleeping than they are awake. And if they sleep during the day, that's okay. Because some people get really upset because they feel people should engage and be awake during that time, because now it's time to do stuff and to discuss stuff. But part of sleep and dreaming is for people to resolve issues in their own life and to restore their bodies. Increased pain I've put as a marker in terms of physiological thing, because we often find in our patients at end of life, pain increases. We very often find that because the cancer is rapid, because the cancer is progressing, it invades structure, so it makes the pain worse. But even in patients who don't have pain, who are simply lying in bed, the simple motion of turning a patient and changing a nappy can be particularly painful. The motion of bending someone's leg or arm can be painful, because and I always say to people, it's like getting in a car and you drive for 5 hours and you're 40 years old, and when you get out after the car, you feel like you're 60 years old. It's a similar thing that happens to patients. And the moment we move these patients or change their musculature, we activate their joints, we activate their muscles, and it can be particularly painful. So even for patients who don't have cancer, towards the end of life, there is a sensation of increasing pain. And we often also see autonomic dysfunction, where the brain's registration of pain is abnormal. And you may or may not have heard about people saying, don't touch my skin when they're close to death, and they will say to you, oh, it's sore. So even touching the skin can be painful for patients. I'm going to the next slide. The psychologically, and this is also a big thing. Death and dying or end of life comes not with just the physical stuff that we as palliation practitioners have to treat. It's also all the psychological and emotional stuff that that surrounds a patient. So there's the attitudes of the doctors, the carers, and I include here in the family, close family, as well as the patient, and all the emotional stuff that goes through these patients and through the carers and through the families. Mental and behavioral changes include withdrawing and reflection. Okay, so patients do become much more reflective and they withdraw. Their worlds become very small. And they go from active human beings going out, eating, drinking, shopping, socializing, to being homebound, maybe be able to walk in home with a walker, eventually short distances, eventually it gets to just shower and back, toilet and back, eventually completely bedridden. So their whole experience of what happens to them gets smaller and smaller and smaller, and they do get more withdrawn. Confusion and disorientation is almost part of what happens towards end of life to a large extent. I think it's a coping mechanism very often, but it also is part of that process of dysfunction that starts happening. And it's quite normal for patients to get confused and disorientated during the latter parts of their life. We often have people complaining that the patient is maybe having delusions or hallucinating. I think it's important to understand that some of those delusions, hallucinations, are very real end-of-life experiences that patients are having. Because as we transition and our spirit and our mind gets a little bit more disconnected from life, we often start hearing, and you would probably find that you've heard people before talking, you need to let Opa in, he's at the door. Or I would have family members saying to me, my mom told me yesterday that her sister was here and her sister died 10 years ago. Okay, those are very real things, manifestations. So they speak what we call the unspeakable almost, because we don't see things that they see and understand things. And very often they see things on the other side. And they would often verbalize that I want to go home. So we had a patient recently that was in hospital, kept on saying to the family, I want to go home. And I arrived and I kind of was talking to the patient. And eventually I said to the family, guys, I think this has got a double meaning for your mom. She wants to go home. I understand that. And she tells me about it. But she's also telling you she wants to go home. She's ready and she wants to die. She wants to go. She's had enough. So it's important that when you listen to patients that you understand that sometimes it can be if you don't understand and you don't connect, that you might miss opportunity where you miss cues what patients are actually telling you. Loss of energy is a big thing that we're dealing with. We often find that patients complain, I just have no energy. And it's a complaint that we often find. It's a very difficult symptom to treat to a large extent, because part of this process of dying is that your energy gets less and less. You're also eating less and less. You're sleeping more and more, and you're not exercising or actually exercising as much as what you used to. Fear is almost universal. I think we all fear death to a large extent, or to a lesser extent. I've had people who have been very comfortable with death. A lot of people would verbalize that they're not scared of death, but they're scared of the process in between. It's the dying that worries them, not the actual death. And that's why palliative medicine is important, is to address all these issues. You'll often find that when patients are at end of life, they start dealing with buried emotions. So they sort out all the strife and stuff that's been between them and friends, between them and families, children, spouses, exes. There's often a reconciliation towards the end of life. And it's important that if that gets acknowledged, I think from various aspects, because it would make the process of death a lot easier. I think it's important also to understand, and I always have a friend who always says to me, he thinks that we die the way we live. And I tend to agree with that with a large extent. I think that people that are at peace with life have a relatively peaceful death. people who fight and are uncomfortable in life, and there's always issues. I think death doesn't come so easy for those people. And I've seen that. I've seen people have really peaceful deaths, and I've seen people having extraordinarily difficult deaths. Death is not always easy, and that's really important to understand. For some people, death is going to bed, sleeping, and never waking up. For some people, death at the end of life is a period of a couple of weeks, and certainly when they're busy dying, 3 or 5 days. And all the emotional and the physical constraints that come with that, and the problems that we pick up as palliation practitioners, and how we deal with that. So it's really important to understand that people, to a large extent, when they die, determine almost the way that they die. And they will go through that process, and they have to almost complete that process. You will find that we often find that if patients don't complete that process, the death is more difficult. People who are ready to let go and then let go and let things happen have a much more peaceful process at the end of the day. But it is a process that needs completion, and no death is the same. So patients don't experience death the same, and neither do family members experience death the same. And family members between themselves all have a different experience. And I always say to people, understand that you're all working, you're all going to the same destination, but you all have a different road that you're walking. So don't make your problems at the end of the day the other person's problems or the patient's problems. You need to deal with the road that you're walking on and holding hands at the same time. And that's really difficult sometimes to accomplish with patients and with families. I think the other thing that I just put at the end is really the grief that comes from this. And grief is something that I think starts very often on diagnosis. People don't always acknowledge it, and sometimes acknowledge it too late. Because this whole process that we're talking about, when patients get diagnosed and until they eventually die and afterwards, is a process of loss. And it's a process of loss that needs negotiating. And some people are very good at negotiating loss, but I think we've become very disconnected, either because we're spiritually not connected anymore, or we're not religiously connected anymore, or we just don't understand things to a large extent and do things our way, and can be really stubborn, and it can make it really difficult to go through grief and through loss. And grief and loss is a whole subject on its own. I mean, we can talk for hours about grief and loss and the complications that as a result of that. But it's important to understand that grief and loss is important to recognize. And in dealing with loss and going through stages of loss, you would actually be able to successfully negotiate this road of loss and make the grief easier and make the bereavement easier. And I think at the end of the day, the message that I've got is that you want to look back when you've looked after someone and said that you made the right decisions for that patient when the patient could no longer do it, and that you have fulfilled the wishes that they had as a patient for themselves during this journey. I always say to families and to patients, don't make decisions you're going to regret. So take time to make the decisions, get the information. And when you look back, you can always say, at that point in time, that was the correct decision. On that time, that was the correct decision. And I think that's really important. Just in ending, just 2 or 3 quotes. Monet, you can show me, and I've just brought them up. I just thought they were quite funny. The first quote was really from David Bowie, where he basically said, I've now decided that my death should be very precious. I really would like my death to be as interesting as my life has been, and it will be. And I came across this quote from Marilyn Monroe, where she basically said, in life, we weep at the thought of death. And I think we all understand that. But I think it was quite wise in saying that in death, perhaps we weep at the thought of life. Because I think patients that are in process of dying and they accept the dying are quite happy to die. We sometimes the ones that don't want them to go, but we are. And I think the last quote that I have is just from William Shakespeare from many, many years ago, when medicine wasn't even as advanced. And he already said, by medicine, life may be prolonged, yet death will also seize the doctor. And I thought that was quite a profound quote from many centuries ago. Well, thank you very much. I hope you all enjoyed the talk. And if there's anybody who's got questions, I'm happy to take a couple of questions.
Dr. Schutze, most of the questions which were asked, I think you have already answered, and I think our time is up.
Okay.
So we will, the talk will be on our website, so people can listen to it. And then Amane also said we can send some questions to the practice's email address.
Okay.
And from our side, most insightful. You're a very wise man. You're a very clever man, and I can see that you have a lot of experience in this field. And we wish you everything of the luck. Of course, from our side, we will always be making use of you as a practice. Thank you so much for everybody.
Thank you very much. And thanks to everyone for attending. I hope it was helpful. I hope it gave some insight. I just wanted to say that a lot of the stuff that I've discussed, there's a little book, if you've never heard of it, called Crossing the Creek. And if you download it from the internet, it will give you a lot of insight around death and dying. It's a really important book, I think, for almost all palliation practitioners to have, and I'm sure most of us do know it and have it, but also for families and for patients. So it's called Crossing the Creek. It is in the end, at the end of my talk, there is a reference to it if people want to get hold of the book.
Wonderful. Thank you, and keep well.
Right.
Thank you.
Right. Lots of love. Have a